On behalf of our outstanding faculty, I'd like to welcome you to Critical Care Medicine Academy. My name is Pete Sloan, and I will be the first faculty presenter. Let me share a little bit about myself before we move forward. I'm a graduate of Cornell University Medical College and underwent my specialty training at Thomas Jefferson University Hospital in Philadelphia. I am board certified in internal medicine, pulmonary medicine, and critical care medicine. Without dating myself too much, I can say that I was in the first group of diplomates to sit for the Critical Care Medicine Board when it was first offered in 1990. I have been in practice as a pulmonary and critical care medicine in the Baltimore, Maryland area since 1991 at MedStar Union Memorial Hospital and Good Samaritan Hospitals, as well as Johns Hopkins teaching faculty with a focus on teaching and training medical residents and students. I was a principal investigator in the National Institute Health's national ARDS network trials that you will be hearing about today. Some of my teaching appointments, leadership positions, and teaching awards are listed here. I have no conflicts to report regarding this program's content. Before we get started, let me go over the organization of Critical Care Medicine Academy. The course is divided into 10 sessions, with each session ranging from 1 to 2 hours in length. Prior to each session, there is an ungraded 5-question pretest to allow us to learn more about our students' backgrounds and fund of knowledge. Each session is divided into several parts. We have posted the PDFs of the slide decks on our Learning Center for download. At the end of each of the 10 sessions, there is a 10-question post-test, which includes the 5 pre-test questions. The post-test requires a 70% score to receive CME credit. After each post-test, you will receive detailed explanations as to the correct and incorrect answers, and you will be allowed to reattempt the post-test an unlimited number of times should you score under 70%. CME certificates for each session are available for download once the session is completed. Before we jump into today's session, let me show you how this session fits into the 10 sessions that make up this series. I will be your faculty presenter for Session 1, Respiratory Failure and Mechanical Ventilation. Session 1 is divided into 3 parts. First, this talk on acute respiratory failure and pulmonary physiology, to be followed by an overview of mechanical ventilation and a discussion of ventilator weaning and non-invasive ventilation. The other topics are listed here. Let me take a minute to review the learning objectives for Session 1. By the end of this session, you, the learner, should be able to summarize the indications for mechanical ventilation and ventilation goals, describe basic lung mechanics, recognize and prevent ventilator-induced lung injury, appreciate the benefits and deleterious effects of PEEP and auto-PEEP, understand modes of ventilation, manage ventilator patient asynchrony and basic ventilator alarms, differentiate between weaning and extubation strategies, and describe principles of non-invasive ventilation. So why don't we jump into Session 1, Part A, which is acute respiratory failure and pulmonary pathophysiology. For those that have completed Pulmonary Academy, a few of the slides I will be showing today will be a review, as lung physiology is the same whether in the context of pulmonary medicine or critical care medicine. So let's start with some basic definitions. We typically divide acute respiratory failure into 3 broad groups: acute hypoxemic, acute hypercapnic, and mixed acute respiratory failure. Acute hypoxemic respiratory failure is defined as the presence of severe arterial hypoxemia that is refractory to supplemental oxygen but with preserved ventilation that is either normocapnic or a PCO2 near the patient's baseline. Acute hypercapnic respiratory failure is defined as an elevated PCO2 and reflects an imbalance between CO2 production and elimination. The PCO2 in the blood is a ratio of how much CO2 is produced divided by how much is eliminated, so that either increased CO2 production or decreased elimination will raise the blood PCO2 level. Now, how do we eliminate CO2? Elimination of CO2 is proportionate to the alveolar ventilation. Alveolar ventilation is how much of the ventilation reaches the alveolar unit. The alveoli are very efficient in eliminating PCO2 as long as air reaches the alveolar units. Well, there are two main ways we can raise alveolar ventilation. We can increase the respiratory rate, or we can increase the tidal volume. So either of those, as we know, will increase CO2 elimination and lower the PCO2. But we have to remember that part of the tidal volume that we are delivering to the patient is what's called dead space, which we'll talk about in a few minutes. Dead space is the part of the tidal volume that does not participate in gas exchange, and there are really two types of dead space we'll get into, anatomic and physiologic. But for the purposes of understanding CO2 elimination, suffice it to say that we simply have to decrease the tidal volume by the dead space to understand how much the tidal volume is contributing to CO2 elimination. So for example, if our tidal volume is 500 cc's, but the dead space fraction is 200 cc's, then only the difference, or 300 cc's, is participating in CO2 elimination, so that an elevated dead space will decrease CO2 elimination. Now, we were talking a moment ago about increasing CO2 production. This can be caused by increasing metabolic demands, fevers, or change of nutritional substrate. For example, carbohydrates have a higher CO2 production per unit of oxygen consumption than fat or other substrates. Finally, decreased CO2 elimination can be caused by excessive load on the respiratory tract, severe lung disease, pump failure, which is when muscles such as the diaphragm or accessory muscles of ventilation fail, or the CO2 elimination can be decreased on a central mechanism such as central respiratory suppression. We see narcotic overdoses as a common mechanism of central respiratory suppression, leading to decreased CO2 elimination, which in turn will lead to a rising PCO2. Now, I mentioned that we do see patients with both hypoxemic and hypercapnic respiratory failure. These typically are the worst patients, and they are frequently requiring non-invasive ventilation or even intubation. Let's turn our attention to the initial evaluation of patients who were diagnosed with acute respiratory failure. First, we must assure an adequate airway, part of the ABCs. We can establish an oral or nasal airway, and if necessary, intubate the patient. Next, we need to address oxygenation relative to supplied oxygen. For example, if someone's on room air and their saturation is low, we'll obviously supply at least nasal cannula oxygen, or possibly escalate the oxygen delivery. If regular delivery doesn't help, we may decide to use high flow, CPAP, or BiPAP to help pressurize the oxygen and improve gas exchange based principally on alveolar recruitment. Now, how well our blood oxygenate depends principally on how high we can achieve an alveolar oxygen called P sub A, the alveolar oxygen, and it's a capital A because the arterial oxygen is a small a. The two main determinants of alveolar oxygen are the ambient FiO2, which on room air is 21% but can be raised with supplemental oxygen, and the atmospheric pressure, which at sea level is 760 millimeters of mercury, which is called 1 atmosphere. Now, even though these are the two main factors, we have to consider some corrections. First of all, we can obviously raise the FiO2 with supplemental oxygen. That will help raise alveolar oxygen. We have to remember that atmospheric pressure of 760 has to have a correction for the water vapor pressure, which is 47. So it's 760 minus 47 is how much space is available in the atmosphere to contain oxygen. That's obviously multiplied by the fraction of oxygen, which can range from 21% to 100%, depending on how much supplemental oxygen. Finally, the level of PCO2 in the alveoli inversely impacts the alveolar oxygen, so that as PCO2 rises, the P alveolar falls. Notice the minus sign right here. This is a consequence of the alveolar gas equation, but pure hypercapnic respiratory failure by necessity always lowers alveolar oxygen and causes hypoxia, even in the presence of healthy lungs. Now, once we have a sense of the alveolar oxygen tension, if we calculate that with this formula, we can actually calculate something called the arterial to alveolar gradient, the AA gradient. It's simply the alveolar oxygen minus the arterial oxygen. For example, on room air at sea level, a healthy person might have an alveolar oxygen of 100 and an arterial of 85. And in that case, 100 minus 85 is an AA gradient of 15, which is pretty normal. When we have people on high FiO2, the alveolar oxygen might be 300 and the arterial might only be 60. And then we would say the arterial to alveolar gradient of 240 is elevated. Now, this equation that I showed you a minute ago can simplify on room air at sea level, because on room air we know FiO2 is 0.21, and at sea level we can put in 760 and 47 for the atmospheric and water pressure respectively. So this entire fraction here, or the entire product of FiO2, P atmosphere minus P water, simplifies to 150. So for example, on room air at sea level, if your PCO2 is 40, then the alveolar is 100. That's 150 minus 40 divided by 0.8. That comes to 100. And that's what I was saying a minute ago. On room air, a regular healthy person should have an alveolar of 100 when their PCO2 is 40. And that's why when their PO2 in room air is 85, their AA gradient is 15. Now, our target with treating patients should not be a completely perfect PO2, but an acceptable PO2. We tend to target PO2s in the 60 to 70 range, which should achieve a saturation over 90%. After going higher on PO2, there's only a modest further change in the saturation. The saturation can only go as high as 100%. So we're very happy when the PO2 is in the 60s or 70s and the saturations are over 90%. So our next part of initial evaluation and management of patient with acute hypoxic is to support ventilation. We can use bag valve ventilation if necessary, non-invasive ventilation, or even a ventilator if they are intubated. Our target should be a PCO2 to achieve a pH of 7.35 to 7.4. Now that in a normal person could be a normal PCO2 or a slightly higher PCO2, but not every patient needs to have PCO2s near normal. I'm going to show you 3 exceptions to when we're not necessarily targeting a PCO2 of 40 to 45. First of all, if a patient has a primary respiratory alkalosis, we may not be able to target this pH. The pH may be elevated from the primary respiratory alkalosis, let's say 7.5, and their PCO2 may be 32. And if a patient's primarily hyperventilating, there's nothing we can do. We just have to allow them to have a high pH and a relatively low PCO2. There's really no good way to target a higher PCO2 short of heavily sedating or paralyzing the patient. Another time we have a different goal of PCO2 is in a chronically hypercapnic patient. We don't need to target a normal PCO2 of 40 to 45. We can target their baseline PCO2, which might be 60 or 70. That will typically still keep their pH close to normal, about 7.3 to 7.4. And the third time we don't target a PCO2 of 40 to 45 is if we're using a permissive hypercapnic strategy. We're going to go over that when we talk about management of ARDS. But in permissive hypercapnia, we have no choice but to allow the PCO to remain elevated, let's say 60 or 70, even if that's a low pH as low as about 7.2. Other considerations in the initial evaluation and management of patients with acute respiratory failure include establishing vascular access, almost always intravenous access and possibly arterial access, obtaining an ABG and possible VBGs to help us to distinguish whether there's pure acute hypercapnia. That would be an elevated PCO2 without a base excess. That is, the kidneys have not had time to accumulate bicarbonate to compensate the hypercapnia. Another pattern we might see on an ABG or VBG is acute on chronic hypercapnia. That is, there's some base excess, but still a low pH, indicating that there hasn't been enough time to completely compensate. Finally, there could be chronic hypercapnia where there's enough time to accumulate a base excess through renal mechanisms to close to normalize the pH. So these blood gases help us understand the state of compensation for hypercapnia. They also give us an accurate reading on the oxygen level and saturations independent of what we can tell from oximetry, which is sometimes inaccurate. Other modalities that we may lean on at the time of initial evaluation of a patient with acute respiratory failure are the physical examination. That can be very helpful. We might hear wheezing, discern crackles at the lung bases, look for edema, jugular venous distension, lots of things we can see on exam that might help us understand the mechanism of acute respiratory failure. We, of course, obtain imaging. Virtually all people, as you know, that are having respiratory failure have a chest x-ray, and some have CT scans of the chest and other specialized imaging, such as a VQ scan or another image to help understand the mechanism of respiratory failure. I like to review the waveforms on the mechanical ventilator. They give me a lot of information about the mechanism of respiratory failure. The expiratory flow pattern is very helpful in looking for airflow obstruction. A prolonged expiratory flow, especially flow that is still present at the end of expiration, almost always shows airflow obstruction. I also like to look at the waveforms to calculate lung mechanics. I'm going to show you in the ventilator talk how we can use a plateau pressure at end inspiration to help us calculate the lung compliance, which is a measure of how stiff the lung is, and the lung resistance, which shows how much airflow obstruction there might be. This is very helpful on patients who are on mechanical ventilation.
I'd like to review some healthy lung pathology with you. In the first frame, we see a healthy appearing bronchus with cartilage, some stroma, the epithelium lining of the lung of the bronchial surface, and the lumen. This more close-up view shows some mucinous glands within the stroma, smooth muscle, cartilage, epithelial lining, and over here the luminal side. This is a terminal bronchial, I should say, going into an alveolar duct, which is entirely lined by alveoli. And finally, the end of the road is the alveolus with the air spaces and the interstitium with its capillary network. Let me zoom in on this interstitium here a little bit. So we start with the air spaces over here, the alveolus, which is ventilated all the way from the mouth through the large airways conducting into the respiratory airways down to the alveolus. These are type 1 pneumocytes over here, which are the main lining cells of the alveolus, the epithelial cells. They spread out and create the membrane. A larger type 2 pneumocyte is a surfactant-producing cell and also a regenerator cell for any lung damage that occurs at the alveolar level. The interstitium is the space within the lining of the lung that is part of the separation between the air spaces and the capillaries. The epithelium forms part of the barrier between air and blood. And here's a lung capillary with some red blood cells in it. This green is really the three sections of the interface: the alveolar epithelium, the interstitium in between, and the capillary endothelium. This interface right over here is what oxygen has to cross from the air into the blood and what carbon dioxide has to cross on the way out. So let's discuss determinants of tissue oxygen delivery. An average-sized person consumes about 250 cc's of oxygen per minute. Oxygen is delivered to the tissues at about 1,000 cc's per minute, so that 25% of the oxygen delivered is extracted by tissues. This 25% is called the extraction ratio. How does oxygen get delivered? Cardiac output times blood oxygen content, that is, cardiac output times blood oxygen content equals oxygen delivery. For example, if we send 5 liters of blood per minute to the body and each liter contains 200 cc's of oxygen, then we've delivered 1,000 cc's to the human body. Low oxygen content can be compensated by increased cardiac output. Let's discuss determinants of oxygen content. Hemoglobin can hold up to 1.34 cc's of oxygen per gram of hemoglobin. Hemoglobin is the most important factor determining oxygen content. For example, dropping of hemoglobin from 14 to 7 grams will decrease oxygen content by approximately 50%. The hemoglobin oxygen saturation is defined as the percentage of hemoglobin containing oxygen. The oxygen saturation is the second most important cause of a low oxygen content after the hemoglobin level itself. For example, a typical fairly severe drop of oxygen saturation from 100% to 85% will only decrease the amount of content by 15%. Dissolved oxygen is the least important determinant of oxygen content. This is how much oxygen is dissolved in the blood, not attached to hemoglobin, and is measured as the oxygen tension, or PO2, in units of millimeters of mercury. Only about 2% of oxygen in the blood is in the dissolved form. The rest is on hemoglobin. Thus, anemia or low oxygen saturation will lower the O2 content. Let's discuss the relationship between oxygen tension and hemoglobin saturation, known as the hemoglobin-oxygen dissociation curve. At sea level, atmospheric pressure is 760 millimeters of mercury, and since oxygen comprises 21% of air, the oxygen tension at sea level is 150 millimeters of mercury. At the alveolar level, the oxygen tension is only 100 millimeters of mercury because some of the space is occupied by carbon dioxide, which is extremely low concentrations in the atmosphere but significant in the alveolus. Carbon dioxide here is a white dot with 2 green dots, representing carbon and 2 oxygens. So the trick here is to get oxygen to move across the membrane while carbon dioxide moves out of the lung from the membrane, from the capillary side of the membrane to the alveolar side of the membrane. In this example, the alveolar oxygen tension is 100, where the capillary oxygen tension, known as P arterial O2, is 90 millimeters of mercury. This tension of 90 millimeters of mercury is enough dissolved oxygen to create a saturation of 98% in the red blood cells. In this example, the difference between 100 millimeters of mercury in the alveolus and 90 millimeters of mercury at the capillary side creates a gradient of 10 millimeters of mercury known as the alveolar arterial or AA gradient. So how does O2 tension directly relate to hemoglobin saturation? In this last example, we saw that a tension of around 90 created a saturation of 98% right up here, but a common point on the curve is a tension of 60 is all that we need to create a saturation of around 90%. So the critical oxygen tension we strive for in critical care medicine and in pulmonary medicine is a PO2 over around 60 so that our saturations are into the 90s. Notice that this relationship is truly a curve. It flattens out at the top, so as the PO2 goes over 70, there's very little more oxygen carried by the blood, but when the PO2 goes below 60, the oxygen percentage falls off very rapidly. Also notice that the position of the hemoglobin oxygen dissociation curve moves to the right or to the left based on other factors such as a low pH, a high level of 2,3 DPG, or elevated temperature shifts the curve to the right, favoring unloading of oxygen off of hemoglobin. That makes sense physiologically. In the extremities, when the pH under stress is lower and temperature might be warmer, we'd like oxygen to have less affinity for hemoglobin and fall off of the hemoglobin, so that's what we call a rightward shift. 2,3 DPG is part of maternal fetal circulation, and elevated levels at the fetal side of the placental barrier favors oxygen coming off of hemoglobin into the fetal circulation from the maternal circulation. The shift goes both ways, so that elevated pH, low levels of 2,3 DPG, or low temperatures favors more stringent or tighter binding of oxygen to hemoglobin, shifting the curve to the left. So let's review a case to help us better understand determinants of tissue oxygen delivery. You just evaluated 4 patients, all male, approximately 70 kilograms and 68 inches tall, in the ICU that are all under continuous monitoring with a pulmonary artery catheter, oximetry monitoring, and routine laboratories. Which of the following would be expected to have lowest tissue oxygen delivery measured in cc's of oxygen delivered to the body per minute? Patient 1, who has a normal cardiac output at 5 liters a minute, normal hemoglobin at 14 grams per deciliter, and normal O2 saturation 98%. Patient 2, whose cardiac output is low at 4, otherwise normal hemoglobin and saturation. Patient 3, whose hemoglobin is low at 8, otherwise normal cardiac output and saturation. And patient 4, whose saturation is moderately low at 85%, but hemoglobin and cardiac output normal. Let me let you think about this for a second, and I'll go over the answer. You could pause, of course. So the correct answer is patient 3, the patient who has a normal cardiac output but is moderately anemic at 8 with a normal saturation. This patient's hemoglobin is low by about 40%, so the oxygen delivery will also be low by 40%. The patient who has a normal hemoglobin but a low cardiac output at 4 will have a low oxygen delivery but only down by 20% because the cardiac output is 4 instead of 5. Likewise, the patient whose saturation is 85% will have a lower oxygen delivery than patient A, but only by about 13% compared to about 40% for patient C. So again, a moderate anemia is much worse for oxygen delivery than a moderate oxygen desaturation. I wanted to thank you for making it through Part A of Section 1, and please join me on the other side. Part B of Section 1 will follow. First, let's discuss ventilation-perfusion mismatch, or VQ mismatch. This is the most common physiologic mechanism of hypoxia. Overventilated areas of the lung relative to blood flow can only minimally increase saturation due to the flat part of the hemoglobin oxygen dissociation curve. So here again is the hemoglobin oxygen curve. It's flat at the top so that as the PO2 goes up over 60, there's only a small rise of the saturation from, let's say, 90 to 100. Underventilated areas can dramatically decrease saturation due to them being on the steep part of the curve. So here we see as the PO2 falls from 60 to 40, a smaller fall, the saturation goes from 90 to 65%. So a smaller change of PO2 caused a bigger change in saturation in the wrong direction compared to this large change of PO2, which only modestly increased the saturation. When we mix bloods from high ventilation perfusion areas of the lung with low ventilation perfusion zones, we create a lower saturation than mixing blood from lungs with good VQ matching. Let me show this to you by two pictures. In the first slide, we have even ventilation, two lung zones, each evenly ventilated, each with good saturations of 98%. When the blood mixes together from the two sides, saturation is 98%. Now here's an example of VQ mismatch. Relative to perfusion, demonstrated by these blue cylinders, this lung is overventilated, and this lung over on the left is underventilated through a healthy membrane, which is the red bar. So let's see what happens here. Because of underventilation, the saturation goes down the steep part of the curve from 97% to 70%, where the overventilated area has improved saturation from 97% to an absolute maximum of 100%. Of course, when the blood mixes together, it's 85% desaturated. So just to repeat, the fact that this saturation went up didn't come close to compensating for the fact that this saturation went down to 70%. This is an actual ventilation perfusion scan, which is used to exclude the possibility or to look for the probability of pulmonary emboli. In this scan, we see ventilation is homogeneous in both lungs, showing that the air gets everywhere, but there are perfusion defects, like over here there's a triangular shaped defect that causes ventilation perfusion mismatch, and of course patients with pulmonary emboli have oxygen desaturations for that reason. VQ mismatch is the mechanism of most of the hypoxia associated with pulmonary embolism. Here are several of the defects pointed out specifically. Now the next mechanism is shunt. In a shunt model, the blood is returning to the right heart as venous blood, and the entire cardiac output, Q is flow and T means total. The total flow of blood returns to the right heart into the pulmonary vein to head towards the lung. In a shunt, a fraction of the blood called the shunt fraction travels through the lung but bypasses the alveoli. There's a short circuit, the blood goes straight through. The remaining blood still goes to the alveolar capillary interface, which is over here. Now the blood that makes it to the capillary interface does a fine job of becoming saturated, but then it has to mix back in with the blood that was shunted, and because this patient has a significant shunt fraction, the remaining blood is actually partially desaturated as indicated by purple. So what we define here is the shunt fraction QS over QT is the percentage of blood, or the amount shunted divided by the total, that goes through the lung without making contact with the interface. So here's a case I saw about 2 years ago in the open heart unit. We saw a patient who had perfectly fine preoperative oxygenation before heart surgery. Room air saturation was 97%. Coming out of the operating room, the patient's saturation was 86% on our standard 0.8 FiO2 coming out of the OR. And in fact, we raised the oxygen FiO2 up to 0.8, and the saturation didn't improve significantly. The X-ray shows an entire right upper lobe consolidated with complete atelectasis. And the idea here is any blood flowing past this right upper lobe is shunt blood because it goes through the lungs but doesn't have any chance to pick up oxygen because there's no aeration to the right upper lobe. We actually kept the ventilator going for a few hours, and with positive pressure and time, the lung started to reinflate. You can see that the minor fissure, which had been flat pre-op and was pulled up into this S shape, started to come down towards the normal position. And the oxygenation improved as the ventilation started to meet all areas of perfusion, improving the shunt fraction significantly. By the way, this lobar collapse of right upper lobe pattern is called golden S sign. It's the typical pattern of right upper lobe collapse. Let's turn our attention to an abnormal barrier to diffusion, which can lead to oxygenation problems, occasionally at rest, but more frequently with ambulation. Now in this case, the alveoli is well ventilated with lots of oxygen, and the blood flow into the capillary bed is good, but we're worried that there could be a diffusion limitation, and the diffusion limitation could be caused by decreased area, increased length, or poor quality, a low permeability, which is K. Now in this case, the object is for oxygen to make it across the membrane into the blood. The membrane is represented by alveolar epithelium on the alveolar side, the interstitium of the lung, and the endothelium of the capillary. So there are really 4 ways we can develop a diffusion barrier in a theoretical perspective, or 3 ways I should say. A normal lung is represented by a healthy membrane that has normal area, normal thickness, and normal quality of tissue represented in this shade of red right here. In interstitial lung disease, the membrane is thicker, so the L is larger, and also the quality of the membrane might be lower, so the K is also a lower permeability. The K is lower. So between length rising in the denominator and permeability becoming lower in the numerator, diffusion goes way down in interstitial lung disease. Another mechanism of diffusion is a pneumonectomy, which is represented by one lung, which is totally healthy, and the other lung, which is the other half of this rectangle, is gone. So you have one healthy lung, so you'll likely have diffusion at about 50% because the area is about 50% of what it used to be, even though the length and the permeability are normal. Finally, we can have lost membrane, as in emphysema, where we actually lose some of the membrane pathologically to disease state, even though we might have a normal amount of membrane and no problem with length. So I wanted to show you some pathology. In a normal lung, we see healthy alveolar interface. In the second slide here, the second frame, interstitial lung disease, we can see that it's a thickened membrane with a larger distance between the air spaces and the capillaries, and the quality of the membrane is also down from interstitial scarring. Here's a pneumonectomy. Although the remaining left lung is healthy, quantitatively there's half as much lung because the right lung has completely been removed by pneumonectomy. And finally, emphysema patient lungs, if anything, tend to be larger than healthy lungs, but just because they're larger doesn't mean there's more area. They're larger, but they have holes in the lung, which create a Swiss cheese effect, and this emphysematous loss of lung is the direct mechanism of loss of lung diffusion capacity in emphysema. So now I'd like to turn our attention to exercise-induced oxygen desaturation, a process that typically occurs when patients have a significant diffusion barrier. Let's start with a healthy lung. In a healthy lung, there's a very healthy membrane, which is indicated in red, and at rest, the blood slowly moves through the lungs and has ample time to pick up full saturation. In this case, let's say 99% indicated by the bright red blood at the arrowhead. Even with exercise, when the blood flows through faster, there's plenty of time to get up to 99%. So healthy patients, even when exercising, do not desaturate. Let's take the case of a patient with moderate COPD and a moderate diffusion deficit, let's say a diffusion capacity of 60%. I'm indicating the emphysema by 3 Swiss cheese-like holes in the membrane, showing the pathologic emphysematous changes. In this case, at rest, although it takes longer for the blood to get up to full saturation, there's still enough time to get up to 99%, but with exercise, when the blood's going through quickly, the oxygen saturation might only get up to 85%, indicating a mild exercise-induced desaturation in some patients with moderate COPD. In severe COPD, the problem is even at rest, blood flowing through the lungs slowly doesn't make it up into the 90s, and there's mild desaturation even at rest, let's say 88%. In patients with resting desaturation due to a diffusion deficit, it's a given that with exercise and rapid flow of blood through the lungs, the desaturation will get worse. In this case, the saturation went from 88% at rest to around 70% with exercise. This patient will clearly benefit from oxygen at rest, perhaps at 2 liters, and with exercise, perhaps at 4 liters, where this patient here probably can get away with no oxygen at rest, but is just about ready to start using oxygen with exercise. Let me go through these slides now that you can see them all together. At rest, this patient's blood is saturated with slow flow, and a healthy patient does not desaturate with quick flow. Moderate COPD at rest, they're probably able to keep their saturations pretty good, but with exercise they desaturate. And with severe COPD or any disease with a severe diffusion barrier, at rest there's some desaturation, and with exercise there's severe desaturation. The fourth mechanism of hypoxia is low barometric pressure. Let's start with sea level and then compare to altitude at 10,000 feet. At sea level, we see the atmospheric pressure is 760, the oxygen is 159, and the alveolar oxygen is 98. We discussed that earlier. With an AA gradient of 10, the P arterial is 88, which, based on the hemoglobin oxygen dissociation curve we discussed earlier, creates a saturation around 98%. So these are healthy lungs at sea level. Now, what happens if we take healthy lungs up to 10,000 feet? So the atmospheric pressure is only 480 at 10,000 feet. And that's because the air is thinner. There's less barometric pressure. Oxygen still occupies 21% of the tension in the air, so the PO2 in the atmosphere is only 112 rather than 159. The alveolar oxygen tension is 65, and the PO2 with a normal AA gradient is 54, leading to a saturation of 88% even in a healthy person. The final mechanism of hypoxia is pure alveolar hypoventilation. Marked alveolar hypoventilation, represented by hypercapnia, always leads to hypoxia and desaturation, even in the healthiest person. This is a consequence of either Dalton's law of gases, which shows that the total pressure is the sum of the partial pressures in a gas, or alternatively, it's a direct consequence of the alveolar gas equation, which shows that the alveolar pressure is a product of the FiO2 times the atmospheric pressure corrected for water vapor pressure minus the PCO2 divided by the respiratory quotient. Now, you don't have to worry about this formula too much, but suffice it to say, the FiO2 on room air is 21%. That's a constant. At sea level, this is 760. This is around 43. The problem is, as the PCO2 rises higher and higher from 40 to 50 to 60 to 70, the alveolar oxygen tension goes down. That's a direct consequence of the alveolar gas equation. I won't go into this equation too much, but in the Dalton's law of gases, the sum of the partial pressures equals the total. Same thing happens. As the PCO2 rises, the PO2 has to fall because the total pressure in the system remains atmospheric. So in this example, we see that the PCO2 is 40, represented by a couple of these green, white guys, carbon dioxide. And the PO2 is 88, represented by the green pairs of oxygen. When we have a PCO2 of 40 in a healthy person and a PO2 of 88, our saturation is 98%. This is a patient with healthy lungs but pure alveolar hypoventilation leading to hypercapnia, some sort of hypoventilation syndrome. By the way, hypoventilation can be a primary disorder of the respiratory drive, or it can simply be a narcotic overdose where there's central respiratory suppression. In any event, even a healthy lung with a PCO2 of 80 would have higher amounts of carbon dioxide, represented by more green, white carbon dioxides, occupying space, cutting down the room to fit oxygen into the blood. That means there's less oxygen, less double greens. That preserves the total pressure being the same value. In other words, you can think of it as the carbon dioxide is substituted for the oxygen. The PO2 in this example is 50 and the saturation is 80%, even in a patient with healthy lungs. So how can we distinguish between the 5 mechanisms of hypoxemia using physiologic concepts? To try to distinguish, we ask 4 questions. First, does the oxygenation improve with supplemental oxygen? If the answer is no, we're likely dealing with a shunt. The reason that a shunt doesn't improve with oxygen is that the shunt fraction goes nowhere near the alveoli and would not know whether the patient was on room air or 100%. The blood simply bypasses the lung independent of how much oxygen is delivered. The other 4 mechanisms of hypoxia all generally respond to oxygen. Second, we ask, is the AA gradient normal or elevated? In primary lung disease, the AA gradient is elevated, as in VQ mismatch, shunt, and diffusion barrier, whereby patients with low barometric pressure have low oxygen levels only because the ambient oxygen is low and their AA gradient is still normal with the healthy lungs. Likewise, alveolar hypoventilation has nothing to do with diseased lungs, just elevated carbon dioxide taking the place of oxygen in the alveoli, as I mentioned. Third, we ask, does hypoxia worsen with exercise? As I mentioned in the talk, and I'll mention in one of the problems coming up, this is very common in diffusion barriers, although it's possible in several of these other mechanisms. If the predominant problem is exercise-induced desaturation, then we're usually dealing primarily with a diffusion barrier. Finally, we ask, is the patient at altitude? And if the answer is yes, we have low barometric pressure and the patients will be hypoxic. And in fact, at sea level, we obviously have normal barometric pressure and the low barometric pressure is not a factor. Based on the combination of these factors, we can usually distinguish the principal mechanism from a physiologic standpoint of hypoxia. I'd like to now present 2 cases whose pulmonary issues may best be thought of in light of physiological principles we just went over in terms of mechanisms of hypoxia. The first case is a 75-year-old man who presents with 18 months of worsening exertional dyspnea. Examination shows bilateral dependent crackles. The room air saturation is 93% and with moderate activities drops to 85%. His diffusion capacity is measured in the PFT lab quite low at 40% predicted. The patient is subsequently diagnosed with idiopathic pulmonary fibrosis, or IPF, an interstitial lung disease. The question is, which best describes the likely physiology of the patient's oxygenation problems? A. The patient has developed a shunt from areas of the lung that are still perfused but not ventilated. B. The patient's interstitial lung disease has limited oxygen diffusion from alveoli across the pulmonary membrane into the capillaries. This is further worsened by exercise, which decreases the amount of time blood is in contact with the membranes. C. The patient has developed marked VQ mismatch, causing significant regions of the lungs to be overventilated relative to perfusion, while other regions are relatively underventilated relative to perfusion, leading to low saturations of the blood once mixed back together in the pulmonary veins. D. The patient has developed hypercapnia and reciprocal hypoxemia. Just to go over these options in a more simplistic format before you think about the answer, this patient with crackles, mild resting and moderate exercise desaturation, and a very low diffusion capacity has either A, a shunt, B, diffusion limitation, C, VQ mismatch, or D, hypercapnia and alveolar hypoventilation. Think about this for a minute and I'll go on to the next slide. If you need to pause, just hit your pause button. So the correct answer is B. The patient's interstitial lung disease has limited oxygen diffusion from alveoli across the pulmonary membrane into the capillaries. This is further worsened by exercise, which decreases the amount of time blood is in contact with the membranes. What happens in interstitial lung disease is the membrane is thickened and has poor quality, So two of the factors that determine diffusion is increased length and decreased permeability, or K, cutting into the diffusion. We know the diffusion is low at 40%. At 40% diffusion, we expect that at rest, the blood's not bad, but it's slightly low at 93%. Slow-moving blood can make the oxygen saturation still get up into the normal range, although it's not 98%. With exercise, with the blood going quicker, there's just not enough time to fully saturate the blood, and the oxygen in this case goes down to 85%. Shunt is a different mechanism. I showed it to you before with a pneumonia, where there has to be a region where there's blood flow with no ventilation, and we really don't have any reason to think that that's the case with interstitial lung disease. It's a diffuse process, not a focal process. The third is VQ mismatching is probably in play in interstitial lung disease, but it's a less predominant factor in patients with diffusion barriers. And finally, patients with interstitial lung disease tend not to be hypercapnic. I haven't gone over this. They tend to be normocapnic or actually hypocapnic with a mild respiratory alkalosis. The only way you become hypercapnic with interstitial lung disease is in the very, very end stages. Right pre-terminal, you'll have terminal hypercapnia, but earlier in the disease, the problem's with oxygen, not CO2. The next case is a 40-year-old man seen in Baltimore, Maryland for evaluation of unexplained resting desaturations to 86% on room air. He has no pulmonary history and has never smoked. He is morbidly obese with a BMI of 58, and examination shows clear lungs but diminished breath sounds. Chest x-ray confirms elevated diaphragms, but the lungs are small, although healthy appearing on the x-ray. A sleep study shows no significant sleep apnea. An ABG shows a pH of 7.36, which is slightly acidotic, a PCO2 of 64. I know we haven't gone over acid-base, but that's hypercapnia. 64 is elevated above 40. A PO2 of 55, which is hypoxic, and a bicarb of 37 with a saturation of 87%. Now, we haven't done acid-base, but this is a chronic hypercapnia with a slightly low pH. It's compensated. We'll talk about that in the next talk. In any event, the calculated AA gradient is normal at 15. Saturation improves to 93% by oximetry with only 1 liter of oxygen. Which best describes the cause of this patient's oxygenation problems? A, VQ mismatch. B, shunt. C, diffusion barrier. D, low barometric pressure. E, pure alveolar hypoventilation. Let me let you think about this one for a minute. The correct answer is E, pure alveolar hypoventilation. In this case, I've described an otherwise healthy man, although overweight, who has clear lungs, clear x-ray, clear but diminished breath sounds, and a normal AA gradient. The blood gas shows alveolar hypoventilation with a high PCO2. Most importantly, the normal AA gradient signifies fairly healthy lungs. VQ mismatch, shunt, or diffusion answers A through C would all be expected to have evidence of poor lung health and also would all be associated with an elevated AA gradient. This could be a case of low barometric pressure, but the case is from our hometown of Baltimore, Maryland, which is near sea level, so we have normal atmospheric pressure. This concludes Part B. Looking forward to seeing you in our next Part C, which will be acid-base, continuing our overview of pulmonary medicine in just a few minutes.